Yeah, there he is. That makes sense, yeah. So that will work. For a minute. It's a pleasure. So what? Then I just will start. Do not too much talking, and what I told them is something like 5 minutes for discussion after each presentation, because I think that's the most funny thing. Okay. So it's time or not yet? Still 1 minute left. And there we go.
Jan, he has loaded his slides. So since he has loaded his slides, he's probably
This is that's the curse of modern technology, right? Very transparent. Okay, guys, we can start now. Good morning, everybody. I welcome you to this special topic session, risk scoring and databases. The idea actually originated with Peter Walton, and I guess Ben had some ideas, Peter Capitaine, because we felt together with the database committee that this is really important to discuss several topics in this area, risk scoring and databases, because this is actually what we need to talk about our future strategies in terms of cardiac surgery. And I have the pleasure to welcome our first speaker, Fred Edwards, and he will talk what is the relationship between hospitals, volume, and outcome. What we think is that will be something like 10 to 12 minutes presentations, so we have some time to discuss the presentations.
Well, good morning, everybody. And on behalf of the Society of Thoracic Surgeons, I'd like to thank you for the opportunity to present our perspective on this sticky issue of volume versus outcome. I thought we'd take this approach, start out by presenting a little bit of background information. I think it's good to be able to put things into context in this way. And then talk about the policy implications of this volume outcome link. I'll discuss some of the previous findings with an emphasis on those that have been published just within the last few years. I think probably most in this room recognize that some of the earlier studies were seriously flawed, so it would be worth their effort, I think, to concentrate on more recent findings. I'll then present what we've done in the STS and hopefully be able to draw some logical conclusions from all of that. And speaking of logic, you know, who could argue with this? This has to be true, right? We see it every day in just what we do as we go about the day. And if that's true, then this is a logical assumption here. And we know, though, that while that applies in surgery to some operations, not necessarily at all. And I think for pancreatic procedures, for esophageal resections, probably for bariatric surgery as well, we recognize, yeah, there probably is a relationship between volume and outcome. But how about for coronary bypass surgery? And I think we have to say the jury is still out on this. And why do we care? Well, if we acknowledge that there is a relationship between volume and outcome, it's hard to measure quality as a rule, very easy to measure volume, just to take it from administrative data. So the implication would be we could in fact use quality, a quality surrogate in the form of volume. And secondly, our risk adjustment algorithms. Not many use volume at all. And if it turns out that there's a valid relationship with volume and outcome, then maybe volume should be included in our risk models. And lastly, of course, regionalization. If it turns out that we really do have better results in the higher volume hospitals, then you can make an argument for having large regional centers as opposed to, say, smaller, more rural centers. Well, let's take a look at what's been published out there recently. And I think most of you are aware that particularly in the early years of analysis of this, virtually every analysis was dependent on administrative data. So we'll start with those analyses that focus on administrative data now. And John Birkmeyer has published a handful of articles on this, specifically devoted to the use of administrative data. Here's an article he published in Annals of Surgery in 2006. He used Medicare data that he attempted to risk adjust, and we recognize that there are disadvantages to using administrative data for risk adjustment. And he looked at these 4 procedures. And of course, this morning we're concentrate on coronary bypass surgery. And this was his study question. Does your previous mortality predict your subsequent performance? Does your previous volume predict subsequent performance? And here's what he found. When he looked at mortality rates, he found that they strongly predicted the subsequent mortality rates for a given center. No surprise there. He also found that, again, using this administrative data, that prior volume was strongly related to subsequent mortality rates. And he also found that mortality was far better than volume in predicting this subsequent mortality. So that's the use of administrative data, and Dr. Birkmeyer has published a couple of reports that are along the same lines with the same conclusions. Now, the New York Cardiac Surgery Reporting System is based on clinical data. So let's talk about clinical data analysis in this context. The New York system is one that depends on mandatory reporting, very carefully audited data. He's got good risk adjustment systems primarily through Dr. Hannon's work, and public reporting is an integral part of this. Well, in recent studies from Ed Hannon, they found that risk-adjusted mortality was in fact lower for the higher volume hospitals. And it was lowest for the high-volume surgeons that operated in high-volume hospitals. But if you look a bit closer at his data, and we see that half of the hospitals that were high volume and a third of the surgeons with high volume had actually risk-adjusted mortality rates that were higher than the state average. So clearly you can't just use volume alone to say, okay, if you go to a surgeon with high volume or a hospital with high volume, you're going to have better outcomes. You can't say it. Too much variation. Well, what have we done in the STS in recent years? Our report from 2004 was published in JAMA, the Journal of the American Medical Association. And this depended primarily on information taken from the STS database. And we used our risk-adjusted clinical data. We focused specifically on the hospital level, not on the surgeon level, specifically on the hospital level. Surgeon level was accounted for, but only peripherally. And we looked at both mortality and morbidity. Calendar years 2000 and 2001 were selected, and we had just less than 270,000 patients from 439 centers in this analysis. And when we plot mortality versus volume is on the x-axis here. These are the results you see. And you see, well, it looks like, sure enough, as volume increases, then the mortality does, in fact, decrease. And we looked at things other than mortality. You see the mortality here in the light blue. When we looked at CVA, which is in the orange, you see no change at all. And when you look at both mortality and morbidity, the yellow bars, once again we see that relationship. Yeah, as volume does increase, then the rates do seem to fall off a bit. But what else did we find? Low volume centers consistently had the higher risk patients as compared to the higher volume centers. There was a wide variation across the spectrum, but particularly in the low volume centers. And half of the low volume centers had better results than the high volume centers. So we found a weak volume outcome relationship, and there was no relationship at all when we looked at good risk patients and those patients that were less than 65 years of age. So we concluded that hospital volume is really a poor predictor of bypass care and of outcomes. More recently, we looked at how volume relates to our composite measure. This was an article published in the Journal of Thoracic and Cardiovascular Surgery earlier this year. And for those of you that aren't familiar with our composite score, this is a score that's based on nationally endorsed performance measures, 11 of which deal specifically with coronary bypass surgery. And we looked at 4 domains of care. You can see we had risk-adjusted mortality, risk-adjusted morbidity, and a handful of perioperative process measures as well. And they constitute the elements in our composite. We actually come up with a numeric score. And then we take that numeric score and assign 1, 2, or 3-star ratings to each of the centers. For purposes of our discussion this morning, though, we'll focus just on the numeric score that occurs from this analysis. So we chose to look solely at isolated bypass surgery in calendar year 2007. You see just under 145,000 patients from 733 centers. And when we look at that composite score, this is what we see. Again, we have volume down on the x-axis. And sure enough, as volume increases, then we do start to see this progressive trend toward increases in the composite score. But when you concentrate on these low volume centers, and that's where most people lie, of course, this is what you see. There's a ton of variation, and I'll illustrate this with a slide in just a second. A ton of variation down in the low volume centers in particular. And once again in this study, we found that the low volume centers were at the highest risk. And many in the low volume centers had results that were worse than the high volume centers, but there were some that had better results as well. And we can see that in one of these scatter diagrams here. Each single point represents a given center here. And just look at the variation, particularly down in that low volume area. And yeah, there were a lot of centers that in that low volume area that had worse results as a rule than the higher volume centers. But look at all the centers that had better results than the high volume centers. So this wide variation is something that just has to be taken into account. And again, a pretty consistent finding. So can you say, all right, if we've got low volume, then you're going to have better results than high volume? Not from the information that we have here. So what kind of conclusions do we draw on this? Well, I think we do have to conclude that there is a general relationship. If you look at aggregate data, then the more you do, it looks like the better the outcomes are. But it's a weak association. It is most definitely a weak association, and this wide variation is what produces that. So we can say that high volume does not at all assure quality, but low volume doesn't preclude excellence either. And so I think you can, from this, logically conclude that volume alone is no surrogate for quality. And I'd be glad to field any questions that you have on this.